Okay, performance medicine staff and providers. These are our new consult sheets. You cannot see my face because I am Frankenstein's monster right now. I just got something that we like to call in the industry a baby nose job. But I am going to show you what these new sheets look like, and I'm going to highlight some of the portions and what med staff and nursing is required to do, and then what providers are, and kind of update you on what these look like. If you have any questions, of course, just please call me and I'll walk you through these. The purpose is to make our visits more efficient and also more thorough, because I find that we're asking a lot of the same questions as providers in the room. And if you're like me, I like to take my time, so this is hopefully going to quicken me up. So first off, starting off with the male hormone consult sheet, you'll notice at the top of every sheet now there is a consent form sign and telemedicine. This is for med staff, nursing, medical assistants to fill out. Make sure that they do have a consent form signed. If it is telemed, knock this off. We move down. This is also going to be the responsibility of med staff, nursing, med assistants. Name, date of birth, date of service, and age. I want us to calculate that because I find too, whenever we write soap notes, it's going to be 59-year-old female presents with. So we can go ahead and knock this out if you'll put in the age. Right here, this is also going to be nursing staff, medical assistants. Here for evaluation, follow-up, test RX. I want us to click one of these. First-time visits for hormones evaluation. If it is a 6-week or 4-week follow-up, you click follow-up. Or if they're at 6-month follow-up for in-office testosterone shots follow-up, test RX is going to be every 3 months where they take T home. This big bold thing out here, med date up to list, that are up to date, med list up to date. That is nursing med staff. Click and initial. Denies history of breast prostate cancer. This is going to be for providers, okay? I think it's important that we rule this out and we don't have to document, especially for first timers. We can click that. This is going to be nursing med staff and medical assistants. This is new, current hormone treatment. If they are on testosterone 100 milligrams once a week, we write that right here. If they are also on no hormones, you can put a big circle and click it like this with an X through it, or write none. That's important that we put that on there because as providers, we get to go in and say, what are they actually taking? This is where providers are going to take over. Lab results, symptoms, and the rest of this is going to be med providers. Lab results will have the date of last lab, labs drawn within blank of last injection or pellet. This helps us know if this is a peak or a trough. So let's say they just got their labs drawn in April and we write that date down, labs drawn within 2 months of a pellet. We know that these are going to be in response to treatment. We cut it out so that we have our 5 main laboratory values: testosterone, estradiol, hemoglobin, hematocrit, PSA. I'll switch that over there so there's a slash over here. Or other. Say if you drew a free testosterone, a sex hormone binding globulin, you can click those right there. Symptoms. The things I changed on these, we kept the same symptoms, so you can click here if you see any of these that fit, especially for first-time visits. Denies all symptoms below relief with current hormone therapy. So if they're feeling great, they're on T, click here and we know that we've alleviated these symptoms. If we haven't and they have some left, then click these. This is also going to be the date of last prostate exam. Really, they should be getting a prostate exam about every 2 years after the age of 40. They can do that with their primary care, or they can do that with us. The rest is going to look pretty similar here. You can write a brief note, or you can check these 2 marks and say see above if this kind of explains the history. Follow-up testosterone RX patients. Med regimen brings relief of baseline symptoms, kind of reiterating what's happening here. Denies the current side effects. Those are all the major side effects of testosterone. If they deny those, I want those to be clicked out every time. Check if they're all. If not, you can click some of these if they're having some of these changes, and that might change your therapy. So here's some fun stuff I'm adding on. So there's add-ons to these. A GLP-1 add-on. How many times do we have an Ozempic, Adderall, and testosterone patient? It can all be done on this same visit. GLP-1 add-on, if they are on Ozempic, or they've started Ozempic, these are going to be where you document that. GLP-1 therapy that you'd like to do, you write in Ozempic, you can write the doses, you can write Trulicity, Rybelsus. Denies history. This is the big contraindications. I want you to click that to make sure you discuss those and sample provided if you did a sample. Adderall, ADD add-on. All these, this is a very truncated view of our ADD or ADHD visit. So you're going to check these are all check boxes. Brings relief. These are going to be for kind of the easy Adderall add-ons. And you're going to write your dosage right here so you do not have to click out a separate sheet. Now we're going to go into our plan. So to our assessment and plan. So I put a little bit different. Hypogonad, suboptimal testosterone levels. So that's going to be kind of for your young guy who doesn't clinically fit the hypogonad diagnosis, but has suboptimal levels and you're treating these, or other. Quick discuss workup follow-up. They're taking injections home. They have self-injections discussed and consent form signed, or other medications lists. You can put other suggestions and they're going to be down here. This is going to be very similar. Injections, pellets, creams by mouth. Providers, put a follow-up. Always put some sort of follow-up. 4 to 6 weeks, 6 to 8 weeks, 3 months, 6 months. No, every visit should have one of these circled. If you want labs followed up, this is nice if as we share patients that, hey, I want this guy to follow up in 3 months with a hormone panel, or 3 months with labs down here marked. I want you to mark these so that the other providers know. These are going to be the risk assessments. With testosterone therapy, I want you to click both of these each time. We'll sign and we'll date. Not much change. We don't do much of a physical exam, so the physical exam stay the same. Make sure the most important things are going to be prostate and breast exam for these. All right, now for the female hormone consult. These are kind of big changes. That's why it's taken a little bit of time, y'all. So you'll notice the same thing is going to be consent form, telemed, all at the top. Bring a copy of mammogram and pap smear. We haven't been really consistent. We kind of take a patient's word if they have done a mammogram and pap, and you'll see it delineated down here. Encourage them to bring copies, and that way we have a copy of it in our charts. I don't think that's a bad idea. It's not necessary. Now, if they don't have one and they don't get one and they refuse to get one, it needs to be documented. Also, too, I think it warrants a call to Dr. Rogers to make sure that he's okay with prescribing hormones and that they know risk benefit. So med staff, nursing staff, med assistants is going to do this top part with name, age, date of birth, date of service. This eval for what they are here for. Are they here for an evaluation, a follow-up? Did we update the med list? We have got to update our med list every time. The bold is going to be providers. Have they had any history of breast or gynecological cancers? No, we click. If so, then we can make a notation under here. Current hormone treatment. This is where it ends with med staff. Write this out, what they're on. If they're on a biased cream, write out the biased cream and doses. We want to know exact doses on here. Or are they on pellets? Are they on T-shots with bi-mouth progesterone? Providers want to know that, and so we can take over from here down. Labs. We're going to have very similar to what happens with the male labs, except there's not an injection for labs drawn within. Just important to know right here, the date and labs drawn within lets us know if this is a peak or a trough and what our expectations look like. We have the big three with estradiol, progesterone, testosterone, or other. That might be FSH. That might be DHEA. I want those documented each time. Symptoms. So very similar to male hormones. Denies all symptom were low. They feel great with their hormone replacement. Check, and we can move on. If they're having some symptoms or this is a first-time visit, here's where we check the symptoms. Here's where we see abnormal side effects. So abnormal side effects might be breast tenderness with a pellet. It might be an abnormal gynecological bleed or a postmenopausal bleed. I want us to document down here if we're having any abnormal side effects. Mammogram and pap and pelvic, we're going to put the date on here, and if it was in with normal limit, we circle, or if it was abnormal, and we can write a little note here. I do want us to check this every time that you have to stay up to date on MAMs, PAPs, and pelvics in order to receive hormone replacement therapy. So now we're getting into our SOAP, our PMH reviewed, brief history. I did put this on here, hysterectomy and partial hysterectomy. That helps us know kind of where they are in the menopausal state. So we can click one of these. If this does not apply, you can just put a big no, or you can mark them out or leave them blank. This up here kind of helps right with the note right here. We don't have to write much for a subjective. So we can say see above, or if it's our first time, we can write a little bit about their history with hormones. But all this is trying to save here. So abnormal physical findings, it still stays the same. There's not much that we do because we don't do female exams in the office. So that's going to be a little bit just filler space. Assessment, we have menopause. Now we have a little bit more delineation of what this looks like because we don't just treat menopause, perimenopause, PMS, suboptimal testosterone levels. How often are we just treating T levels for females or other? We're going to quick discuss workup, side effects each time. Other suggestions of medicines, that might be something like DIM, maybe it's zinc for estrogen. That's where you can put those suggestions. Now we're getting into our plan, and we'll get into our plan for a second. Same thing we have with the male and the female, the male hormone consult. We have an Adderall add-on and a GLP-1 add-on. We do, for men, we usually get a lot of Adderall T patients. For females, we usually get a lot of Ozempic hormone patients. So that's where you can click the GLP-1 add-on to make sure that we are staying nice and safe with our contraindications. Creams, by-mouth pellets, injections, or other meds, you can fill these out here with any changes. Follow-up, make sure to put a follow-up, 4 to 6 weeks, 6 to 8 weeks, 3 months, 6 months. Click or circle one of these if you want follow-up labs, what they look like. If labs are ordered that day, that's the same way with a male hormone consult. If labs are ordered today, you click them down here. I delineated with the big 3 or the big 4, and then kind of thyroid and other things that deal with female hormones. Click, call if any problems, and risk benefits each time. We'll sign and date. All right, now we're getting into our I updated these because I find too that often we're just kind of doing pellets, but we don't really ask. We will ask how they're doing, but it's not always on that sheet for pellets. So this is going to be a male hormone pellets. We'll make sure that consent form is signed. This is front office staff and med staff. Med staff, you're going to do name, date of birth, age, date of service. We're going to leave the rest to the providers. So indications, what are they here for? Most often it's hypogonad or it's menopausal. We do put osteopenia, osteoporosis because that's an indication for a pellet. Pre-op report, I put this on here. You do not have to ask this each time. There's only a few patients that get sutures. But I thought it's nice to know if they do, how many sutures were required and what you used. It's usually going to be 2 4-0s or 1 3-0 for a male. But you can put that here. I wouldn't get in the habit of asking because they might want it, and it's really not needed in every patient. There's only a few, and you kind of know those few, but that way we make sure that we know what that pellet or that suture requirement looks like. Here's where we're going to put the labs. This is what we're kind of updating. It's going to be a review of systems, if they like the pellet and what their labs look like, to make sure we stay up to date. So you can put the date of their last lab and then the big ones of what you found and how long it was from their last pellet. Might be a new one, so you can just click 0 here if they've not had it, or if this is a first-time pellet. So review of systems for initial pellets or terminal end of last pellet. This is probably what we're going to use the most. Patient on continuous pellet therapy feels subtle changes above. So, hey, the pellet's running out. We're going to click check on this. If it's an initial pellet, we might want to go here and click what they're having, or if they're noticing a significant change only in one of these, maybe it's erectile dysfunction, sexual function, you can click and make some notes. Follow-up and continuing patients, I put these on here to see if they actually like the pellet. If you're going to click that first box, if they tolerated the procedure well, no side effects. Patient experienced side effects, you're going to click this box if they didn't like the last pellet. They felt something with it. You're going to make a change with this pellet. Here's where you write that in too, so that helps us know if we share patients what their last pellet looked like. These stay the same, so you'll check and check. Also, to left hip or right hip. Med staff, if you'll click that too, because you're going to come down and help us out down here. Are they on the left or right hip? If you'll circle those. And 2, we're going to put the lot numbers. I know that they're making a change to where there's not going to be many pellets with anastrozole anymore, but this is where we put the lot number. Discuss this with Katie. This is where you can put stickers if you'd like to put the stickers from the actual pellet. It's important to med staff, nursing staff, you're going to put the total number of milligrams right here for T. Providers, you're going to click these 4 boxes, sign and date. Female pellets are going to be very similar too. So the same thing that you see, I only have one female that likes to suture, so that doesn't have to be anything. If sutures required, you can just do this if you'd like, or leave it blank. We're going to put the labs here, providers, med staff, nursing staff, same deal up here. Providers are going to ask these questions, look at labs, review of system for terminal end of last pellet or initial pellet. You can click these, or you can say patient on continuous pellet therapy. They're just ready for the next one. Same thing. Did they like the last pellet? No side effects? Or did something happen and we need to make a change? We changed the millimeter of trocar. Thank you, Robin. Med staff, nursing staff is going to click right or left, and we're going to check these 2 marks. We're going to put the number of testosterone and estrogen pellets in here with left or right hip. Total dosage, we can have med staff, nursing staff put these down. Prescription for oral progesterone, ask each time. Med staff, nursing staff is going to ask this with the milligrams. I have a few patients that are unable to tolerate progesterone. We can click here. If it's a first timer, we can say why. If not, they just don't take it. So we'll click these. If you need to place stickers, you can put them down here. So those are kind of our hormones. Now we're going into weight loss. So weight loss, same thing where we're going to have med staff talk about consent or telemed. If this is over the phone, they'll complete name, date of birth, date of service, age. Here's where we kind of delineated it because this is what we're seeing the most of. Is it an initial diet consult? Is it a follow-up? These are going to be your Ozempic patients. Is it specific to Vitatrim and Phentermine? That's going to be NLP. Is this just Phentermine consult or the HCG program? Let's be specific about that. We're going to click all of these. The med list needs to be updated each time and updated on the front sheet. Vitals, BMI has to be included, especially if you're doing HCG. We need BMI, body fat percentage. You're going to put the weight goal right here, and it can be a number, it can be a feeling. People just want to say feel better. A number is a little bit more helpful. 2, with body fat percentage, weight, and BMI, med staff, nursing staff, include that right here and check this. Providers, this is where we're going to start over, okay, or we're going to take over. Check these 2 boxes, recent labs reviewed, PMH discussed and reviewed. I changed the review of systems, if you'll notice it, because most often what's happening with weight, it's either insulin resistance, thyroid, or hormones getting in the way. So this is going to kind of help delineate what your review of symptoms look like and save some time up here or down here. You can say see above or review of systems. You can say a little bit about their history with weight right here. 2, I'm okay if it doesn't need to repeat 49-year-old female. Dad maybe think a little bit differently, but I want us to save a little bit time right here and we can utilize this. Or you can say see above times many years. I included 2 different boxes right here, a nutrition exercise sheet. What are they currently eating and how are they exercising? Brief notes right here. And there's also recommendations that we commonly say that you can check mark if they make sense to you or if you said them in the room. Increase physical daily activity, decrease carb intake, intermittent fasting, and education on fung nephrology, Gundry's plant paradox. This is for Fran, increase plant-based foods and polyphenols. Phentermine HCG workup. This is going to be very specific if you clicked Phentermine or HCG program. Do they have a history of hypertension or heart disease? We need controlled blood pressure. Phentermine was discussed. HCG was discussed. The changes we make if you go on the HCG program, that's going to be diabetes and hypertension medicines. We have those, and you can notate what that looks like. So our findings for what are our abnormal findings, you can absolutely list right here if you want to click obese, thin, or normal. Or 2, just make some findings of what you might find on thyroid too, if there's thyromegaly. Assessment, obesity, thyroid disease, diabetes, insulin resistance, PCOS, stress, adrenals, hormones. This just kind of gives us a really good gamut of what is causing the weight. We can click that in any notes you need to make. Side effects and medications discussed. If you prescribe a medicine, just click that. Blood pressure and blood sugar and weekly, that's HCG specific. You can click that if that's available or that's what you did in the room. Here's kind of our meat and potatoes. Did we do metformin berberine? You can click these out. Do you have any other med suggestions you want to put right here? hormone replacement right here. If you're going to go ahead and start hormones, this is where you can put it in. They understand the risk benefits. You can also make an additional hormone consult sheet if you'd like. If not, you just want to say, hey, we've talked about this. Here's our hormone risk. We can click this right here and follow up. HCG with phentermine, HCG 40 days, which we don't really do anymore. We can click down here, or Vitatrim injections with NLP. GLP-1 therapy, this is a big thing because you do need to document these contraindications. We can click these, say if you provided a sample or continuance of therapy or change in therapy. Follow up, check one of these or circle. They got to follow up at 4, 5 to 6 weeks, 2, 3, 6 months. PRing yearly is going to be if we're not prescribing medicine. So if they're just in for a weight check, then we can do that yearly. Follow-up labs if you want to see them. So if I get a Pratik patient and he had them follow up in 2 months with hormones, I know that I'm expecting to see those labs, or they're going to draw them that day when they follow up. Referral, we are bringing on a nutrition coach and possibly a trainer. We already have a therapist psychologist on board. These are great tools to use for your weight loss patients. And those can be utilized in all the offices. Robin is our therapist psychologist that comes up once a month to the Tri-Cities. She's there more in the Knoxville office. A nutrition coach and trainer we are bringing on in August, and I'll give you more information on how to refer to him. Labs ordered. If you have any additional labs that you want to see, we can click right here or see that day, sign, and date. Perfect. Med visit. Okay, so med visits, most often, what I just talked about, people are either coming in for hormones or for weight. Rarely, not rarely, but the other stuff kind of gets nuanced, and I wanted to make this sheet a little bit easier. So med staff, we're going to do consent or telemed if applicable. We're going to do name, date of birth, age, date of service. Here's where we are going to kind of get to the meat and potatoes, because if they're just a new patient and they have no idea what they want, then med staff, I want you to click new patient. If they're a new patient but they have an idea, I want to talk about my thyroid, I want to talk about diabetes, I want to follow up from what we talked about last time, an autoimmune illness, or I want to be on low dose naltrexone. If they're a gut patient, or if they need clearance for IVs, all patients who are getting IVs need a med clearance, and this is where we clear it, is in the medical visit. So IV if they're just interested in Myers or vitamin C. Their chief complaint, it's really going to be right here, but say a little bit of the symptoms that they're having in. This is from med staff nursing. And remember, up-to-date med list. This is where we take over providers. We discuss, I want you to click PMH discuss. If they have a new history from last time or they're a new patient, we click here. Quick care, I put this section on there in case we get the sinusitis patients back, or poison ivy. We're kind of seeing some of the general med stuff. You can click quick care and utilize these review symptoms. A UTI, we can use these over here. Abnormal findings, these did not change from last time. They'll be listed on the right. Assessment. So assessment is going to be what you see. You can say see below because I kind of delineated these out. This might be establish new patients, general health. This might be something that you see in quick care. What is it? Is it sinusitis, UTI? You can put your assessment right here, and your plans are going to be differentiated in what they see. Quick care, thyroid, diabetes, we're going to stick up here, and we're just going to check and say Armor 15, or we're going to check and say Metformin 500. Check and say Bactrim DS BID times 7 days for UTI. If we get into the other things, the IV therapy, autoimmune gut, this is where you come down and delineate. So IV, we have Myers, vitamin C hydration. I do want you to say discuss risk benefits each time, providers. If they had a vitamin C, they do need a normal G6PD. I want you to check this. Autoimmune protocol. So too, this kind of helps us out without having to think about it too much. Have you put them on LDN? Have you tried doxycycline for Lyme disease? Did you talk about nutrition or other interventions that you might want to refer to? Gut, did you draw or have a GI map ready? There is a separate GI map visit that Robin put together. Dunwoody colonoscopy, we can say all these things, or if you have a referral for these, or some of the interventions like IGY, BPC 157, and Digest Shield are all gut health. Any other interventions you see fit. Follow up with labs. You want them at 2, 4, 6 weeks, 2, 3, 6 yearly. If you're prescribing a medicine, then I want you to put something less than yearly. It's thyroid 6 months, diabetes 6 months. Yearly can be hypertension, if you have them on a cholesterol medicine, if they're in general health, or 2, if they're just doing as needed Myers or hydration and nothing else, you can do yearly. If you want to see them back with labs, a yearly Cleveland, that's a great place to put it. Insulin resistance labs, that's going to be C-peptide and intact insulin, best on fasting with an A1C and possibly a CMP that has glucose. A referral if you need it. I always say refer to my friend Fran. She'll take care of you. If symptoms worsen, go to the ER. This is going to be especially important too if you're dealing with somebody that's having quick care. Hey, if you're getting that back pain after treating a UTI and it is really bad, go to the ER. Or if you're getting crazy abdominal pain, going to the right because you thought it wasn't appendicitis and it is, that's where you click it. Sign and date. We have new RXs over here with side effects, samples, discuss, and lab orders if you want a different lab order from the set over here. ADD, this hasn't changed much. The only thing I added to this, so same thing, med staff, nursing staff, PMP checked, consent form signed, and telemed if this is on telemed. I think it's important. The reason telemed is important, y'all, is because if we're not getting vitals, that's why. They need to know that. It's like, hey, why didn't you get a blood pressure on an ADD patient? Telemed. We might need to find ways to encourage them to get a blood pressure and check in with us on that. Med staff, nursing staff, you're going to take care of this top half right into the nurse's eval and chief complaint. It may just be refill, new ADD, change in therapy. Same right here. I just updated it. It was DSM-4. Now it's a DSM-5. Follow-up patients, this is where we're going to get easier. Med regimen brings relief of at least 3 baseline symptoms, and they deny the side effects. So check these if they're follow-up patients. Check these 3. And 2, our note can be really small here. You can say see below, especially if they're follow-up. Things I do look for to see if they're having a tremor. Sometimes you can check for their carotids and listen to their heart if you want. They show no signs of drug seeking or drug abuse. I want you to check these each time. Adult ADD, ADHD. Recommended management, just write down Adderall 30 once a day, Adderall 20 BID. Reviewed safekeeping. Follow-up, we need 1 month for new ones, 3 months all others. If you want to order labs or talk about new side effects, you can. Sign and date. Medical cannabis, this is only going to be for our Virginia licensees. It's going to look very similar to Adderall, which is why I put it next to it. Med staff, you're going to do PMP check on each of these patients, consent form signed. If this is over the phone, telemed. Same thing, name, date of birth, age, date of service. New patient or follow-up. So I'll show you what follow-up looks like for this. Chief complaint. This is where it's really important for med staff, nursing staff. What is their chief complaint? Recommendations for cannabis, which is on our protocol, can be anything. Anxiety, nausea, decreased appetite, inability to focus. Most often it's going to be anxiety, insomnia, but write that down here because this is where meds or providers are going to take over, and that's really important. We talked about their history. I want you to check. Diagnosis established. So that's where our recommendation comes in. Anxiety, that qualifies as a diagnosis. Migraines, that qualifies as a diagnosis. That's why that chief complaint is going to be important. And really, they have to be a Virginia residence. Make sure that you see what their license looks like, or they have proof with them that they are Virginia residents. You can write a little bit of note about their history here, if they've ever used it before, or what they've been trying to use in lieu of it. Follow-up patients are going to be at 2 months, which you'll see down here, or 6 months. We see them at 1 month, 2 months for follow-up, and then twice yearly. Med regimen brings relief at least 3 baseline symptoms. I check that. That's going to be like Adderall. And then I put the side effects of what medical cannabis may bring. They deny these side effects. The things I changed here, same, no overt drug abuse or drug-seeking behavior, but also no change with psychiatric or neurological changes in notice. If they look out of it, that might not be a good indication to continue their cards. So checking that's, I think that's going to be kind of CYA on our part. Our assessment is going to match what we see here in their chief complaint or be related to. Is this anxiety? Is this panic? Is this migraines? Is this insomnia? Medical cannabis recommended. This is not a prescription. This is a recommendation. We cannot prescribe Schedule I drugs. So this is a recommendation, and they're actually going to get all the dosing and route of administration from the licensed pharmacist. So with any of these patients, they're actually going to check all these. instructions for obtaining their card. We actually give them that, and that's going to be a nursing staff. We just are going to check that as providers, but that's med staff, nursing staff to get their card, and that is in our protocol. Reviewed safekeeping, go to the pharmacist. They're going to follow up at 2 months, 6 months, and then other if you see fit, but that's really, it's either initial visit, 2 months, 6 months. Labs, if you want, sign and date. Oh, God. Okay, y'all. Forgive me for this, all right? This is also in landscape. This is a Cleveland Heart. This may be something, too, that is a work in progress. This is number 9 out of all of our visits. The only ones I didn't include in this are going to be COVID and GI map. Those have been put together previously by our providers, and I'm very appreciative, and I don't think those need changes right now. But this Cleveland Heart's a doozy, y'all, and it's such a long visit, and I find that hopefully this is a way to be thorough. Hopefully this is a way that if you want to make a copy of this sheet for your patient, they'll know what you want them to do. So too, you don't have to make a separate sheet. I may even find a way to make a separate sheet so that you can click those two and hand it to the patient. This is going to be responsibility of front staff is going to be name, date of birth, date of service, age. That's it. All the rest, and two, I know this is in landscape, but two, okay, I'm going to do this. So we'll just bear with me, because it's going to have to go this way. The only way I could fit this on one sheet was to go landscape. So whenever you do that, it'll be in the chart like this, but then you're going to take it out and maybe you'll put it on front of the chart to actually write your notes. So this is actually going in the order of the Cleveland. So this is all for providers. Med staff, you're only down here. Name, date of service, date of birth, age. Inflammation, cholesterol, metabolic, vitamin status, omegas, genetics, kidney, liver, electrolytes, your CMP, hormones, other hormones like thyroid or cortisol, and blood counts. So all of it's delineated. You can make notes right here if it's high, low, within normal range, needs improvement, perfect, or optimal or non-optimal. History diagnosis, maybe they have a history of fibromyalgia, hypertriglyceridemia. You can put some of that history or diagnosis here, or what you might be diagnosing them with now. Hypogonadism, kidney dysfunction, stage 1 kidney disease. They have an ApoE. I do think it's nice to write what the actual genetics are. ApoE33, MTHFR positive, and maybe what variants. These are going to be into a natural list and a prescription list. This is not exhaustive, but it's a lot of what we end up doing is there. So you'll note naturals for each. If you have any other ones you want to add, I just add it over here with a star for right now. And this is a side effect column, contraindications, and any notes. So too, you'll see that these are kind of the most commons that we use for naturals in prescription. I will say too, cholesterol is a big one to say that you discuss risk benefits of statin therapy. We're not big statin people. If we do, we usually use Crestor 5 milligrams 3 times weekly. But getting a CT calcium for anybody with weird cholesterol is a good idea. And two, if they don't want to be on a statin, but you think they should, maybe you make notation here that you discuss those risk benefits and statin offered. Metabolic, so metformin, a contraindication is actually kidney dysfunction with decreased creatinine GFR. You can click here if you're recommending metformin. And also too, I have put right here that if you're doing GLP-1 therapy, we have the side effect contraindications. Genetics, really our big thing too is to assess your risk factors. So End of Alzheimer's is a great book for ApoE, if they're increased risk for Alzheimer's. Keep Inflammation Low, Replace Hormones is great for anybody with off genetics, or use methyl B vitamins for positive MTHFR. Kind of easy notes about decreasing alcohol if they have increased liver enzymes, increasing salt with good salt, or referral if they need a nephrologist, GI, or hepatologist. Hormones, this is kind of what I'm seeing is that a lot of us are starting hormones with a Cleveland. So I tried my best to include all of the natural prescriptions without anything that's really specific. Did you start them on IM shots, creams, pellets? Females, did they start on creams, progesterone pellets? And then some of the side effect profile and risk indicators. If you start them on hormones, they understand the risks, they have a consent form signed, they deny prostate cancer, breast cancers, chest exam within normal limits, and they've had their regular gyne visits. So we check all these. As far as dosings, if you feel comfortable putting the doses here in small ledger, you can, or updating your med list. Will know because you started them on IM and then you put in the front that they're on 100 milligrams a week. Hormones, these are going to be other. These are thyroid cortisol. So we have, these are pretty self-explanatory. Do they have a history of nodules or thyromegaly? This may indicate that they need an ultrasound, or a referral to endocrinology if it's a little bit more complicated or out of our hands. Elemental iron, prescription iron, therapeutic phlebotomy. This might be for high ferritin levels, secondary polycythemia, to testosterone use, or a referral if they need it. Here's where we're going to have our follow-up down here, which I really like. Do they need a referral? Do they need to go to aesthetics because their face is off? I'm kidding. I'm sorry, but I think it's nice too. We need to, especially too with having another esthetician in Kingsport. We have estheticians in every office except Bristol right now. So we can refer to our aesthetics, refer to physical therapy and Ernie, nutrition, that's going to be in our Johnson City clinic or via telemed or other. Follow-up, do you want them to come back in 6 weeks with a hormone panel, 6 months with an insulin resistance panel, 3 months with thyroid? You can put it here. Alternative test recommended. So this kind of helps out too if we get a follow-up patient. Say I get a Jill patient and I saw that on her last Cleveland, she said she wanted them to get a 4-point salivary curve, or they discussed a GI map. I may see that circled and offer that at the next visit, or see if, definitely ADD quiz. That might be a point of discussion. Here's what we'll sign and we'll date. And we'll put it back in the chart this way. So that is all I have for you. I'm very appreciative. This is going to be a work in progress and I'm amenable to changes, but let's give it 1 to 2 months of using these pretty consistently, see how we like them. And then we may go for another change maybe at the end of the year, or this is going to be our transition into EMR. EMR is going to take a while for us to get just because of our transfer charts. So we're definitely not going to have that expectation by January 2023, but hopefully sometime in the middle of 2023, maybe even further out. I won't make any promises on dates, so we can expect that. We'll have e-prescribing sooner than we'll have EMR. And that's it. Thank you so much.